Hello, everyone. My name's Coleman Rotstein. I'm an infectious diseases physician involved in the immunocompromised host infectious diseases service at the University Health Network of the University of Toronto in Toronto. Today, what I'd like to do is discuss an area of interest to us all, that is COVID-19 vaccines in oncology patients. I have a brief summary here, and I think you can look at this at your leisure. I would like to provide for you my conflicts of interest. I've had grant and research support from a number of companies. I've had honoraria for being a consultant for a number of companies, and I'm also on the Speakers Bureau of a number of companies, having received honoraria from them. I'd like to provide you with some background. How important is COVID-19 for us in oncology patients? Well, it's quite important. We see increased mortality rates associated with COVID-19 in oncology patients. This is particularly pertinent to the hematologic malignancy patients. And in descending order, the most frequent complicated group that runs into COVID complications is acute leukemia patients, followed by plasma cell dyscrasia patients, and then lymphoma patients. In general, those oncology patients greater than or equal to 60 years of age, and those with recent chemotherapy in the past year are at greater chance of higher mortality rates. This is also true, though, for patients with lung cancer. And moreover, if one has comorbid illness such as diabetes or obesity or other comorbid illnesses, those patients have a worse prognosis as well with COVID-19. Well, let's now take a deep dive into the vaccine platforms and talk about the vaccine preparations. Before I get into the vaccines, I have to provide for you some background with regard to the body's immunologic responses to vaccines. Essentially, the body has two separate immunologic response systems. The first one is the adaptive immunity or humoral immunity, and the second one is innate immunity or cellular immunity. So let's look at a paradigm of vaccines such as tetanus toxoid. When we give tetanus toxoid, all we do is we get a humoral immune response, that is antibody production. On the other hand, if we have a vaccine such as MMR, measles, mumps, and rubella, what we get is we get a humoral response, that is an antibody response, but we also get a cellular immune response, innate immunity. And it is the innate immunity that provides the memory cells that remember the vaccine. And in a time when one is re-exposed to that pathogen, that's when that type of immunity kicks in. What about the vaccines? I want to orient you to this slide. In the right-hand corner at the bottom, you'll see the types of vaccine platforms that have been generated. So we have a recombinant protein vaccines, we have virus-like particles, we have vector-based vaccines, messenger RNA vaccines, DNA vaccines, and inactivated vaccines. Let's go through each one. Now, I've outlined here in yellow the various companies who have an agreement with the government of Canada. So Novavax is the first one I want to talk about. This vaccine is a recombinant protein vaccine. It is now in phase 3 study. It has not been licensed yet. Sanofi GSK is not as far along. It's only in phase 2. Now, the government has contracts with these companies, but unfortunately, we don't have the vaccines yet. Now, Medicago is another vaccine producing company, and what they've done is they've produced a virus-like particle. So they take the genetic material of the coronavirus, they infuse that into a plant. The plant is then allowed to grow. The vaccine is derived from the leaves of the plant. So what they do is after the plant grows, they harvest the leaves of the plant, they chop up the leaves, and they make the vaccine from the virus-like particles in the leaves and combine that with an adjuvant, and there you have your vaccine. Now, you do know that the AstraZeneca vaccine, the University of Oxford group, has a vector-based vaccine that is produced with a non-replicating chimpanzee adenovirus. And the genetic material for the coronavirus spike protein is located within that vector. Johnson & Johnson also has an adenovirus vector vaccine. This is adenovirus 26, and this is a unique vaccine that is now in phase 3. You know the AstraZeneca vaccine has been approved in Europe, and shortly it will be approved in Canada. The difference between the AstraZeneca and the J&J vaccine is the J&J vaccine is one dose only. More about that later. Then we have our messenger RNA vaccines, the BioNTech Pfizer vaccine and the Moderna vaccines. Here we have messenger RNA with nucleotides for the spike protein. That is the genetic material for the spike protein in the messenger RNA. And then that goes into our cells, and the spike protein is produced in our cells and attaches to the surface of our cells, and we make antibodies as well as produce a cellular immune response to the spike protein. With regard to DNA vaccines, I'm not going to really mention them because they're really in their infancy. However, I am going to mention the inactivated vaccines because these have been licensed. Sinopharm is an inactivated coronavirus vaccine in China, and Covaxin is another inactivated corona vaccine in India. Now, I want to orient you to the next series of slides. In the far left, you'll have the company that is making the vaccine. In the next column, you will see what the platform is. You will then see if this company has an agreement with Canada. For example, the AstraZeneca vaccine has an agreement with Canada for up to 20 million doses. It has not yet been approved in Canada. My hope is that it will be approved within the next 2 weeks. Now, clinical trials have been done, and the populations involved in the clinical trials are listed here. And over here, we have the results of the clinical trials. So a phase 2/3 clinical trial has been published in The Lancet, looking at the AstraZeneca University of Oxford vaccine, showing that overall it had an efficacy of 70%. But let's stop for a moment and think about this. In that clinical trial in the UK, they gave the vaccine at 2 different doses. The standard dose is 5 × 10⁻⁻⁻ virus particles. Well, what they did in the UK is they gave half that first, that is the low dose vaccine, and then they gave the standard dose as a second dose, and lo and behold, they had a 90% efficacy. I find that hard to believe, but they did. So giving a lower dose created more efficacy because when they gave the standard dose in both doses, there was only about 70% efficacy. And please note another caveat to these results. In those individuals greater than or equal to 65 years of age, the vaccine efficacy was only 43.2%. That is why in Canada, if this vaccine is approved in the next 2 weeks, it'll be approved for people between the ages of 18 to 64 years of age. Now, this vaccine has also been used at times in greater dosage intervals. And surprisingly, when the dosage interval between the two doses is 12 weeks, the vaccine efficacy increases to 82.4%. The vaccine can be stored, as you know, at normal temperatures when the temperatures where we usually store vaccines, that is 2 to 8 degrees Celsius. It has been approved in the UK and India. Let's now talk about the J&J vaccine. This is another adenovirus vector vaccine, as I mentioned just before. It uses adenovirus 26, and the genetic material for the spike protein is enclosed within the vector. This vaccine has gone on to phase 3 trials, and the initial phase 1 and 2 clinical trials were reported in New England Journal of Medicine, but the phase 3 clinical trial, we only have the information through a press release that was released on January 29, 2021. And this showed the vaccine efficacy for just one dose. So this vaccine may be given as one dose or 2 doses, but for just one dose, the vaccine efficacy was 72%, and it worked against the South African variants, 57% vaccine efficacy. It is once again stored at 2 to 8 degrees Celsius. At the moment, there is no approval for this vaccine in any jurisdiction. Now we're going to talk about the mRNA vaccines, the messenger RNA vaccine. The first one I'm going to talk about is Pfizer. You're familiar with this. Essentially, nucleotides are encoded within the messenger RNA, and it's combined with a lipid nanoparticle. The clinical trials have been completed, published in the New England Journal of Medicine, 95% efficacy. Excellent. The only problem with the vaccine is it has to be stored at very, very low temperatures. Once it's mixed and it's at room temperature, its viability is only for a few hours, and then it is no longer viable. This vaccine has been approved in the UK, Canada, the US, and the EU. The Moderna vaccine is another messenger RNA vaccine. The messenger RNA is combined with a lipid nanoparticle. The clinical trial has been completed. That is the phase 3 clinical trial and published in New England Journal of Medicine. It doesn't have to be stored at such low temperatures as a Pfizer vaccine. The temperatures can be slightly higher, but still in the undiluted form, it can now be stored at 2 to 8 degrees Celsius for 30 days. It has been approved in the US and Canada. Now, let's talk a bit more about the vaccine efficacy of the mRNA vaccines. I mentioned the platform. The platform takes nucleotides that code for the SARS-CoV-2 spike protein and encode that within the messenger RNA. This messenger RNA is then combined with a lipid nanoparticle and then is injected into the recipient. Once it's in the recipient, the gene for the mRNA spike protein then goes to the ribosome. So the nanoparticle is left behind, and the messenger RNA goes to the ribosome, and there it codes for the spike protein, and the spike protein is produced in the ribosome. The spike protein then migrates to the cell surface, and our immune system then recognizes the spike protein as foreign And we have both an adaptive and innate immune response, meaning that we produce immunoglobulins, but also we produce a T cell mediated response to the spike protein. The spike protein cannot cause infection, and the messenger RNA is quickly cleared from the body within days to weeks. Now, let's look at the clinical trial using the 30 microgram dose of the Pfizer BioNTech vaccine. Overall, comparing the placebo to the vaccine arms, the vaccine efficacy at greater than 7 days after the second dose was 95%. Even in the elderly, that is, patients greater than or equal to 65 years of age, the vaccine efficacy was excellent. It was 94.7%, showing that there was no senescence, meaning that in people who are older, for example, when we give the influenza vaccine doesn't work as well. That's why we have to use high dose influenza vaccine. Instead of just 15 micrograms, we have to use 60 micrograms of the influenza vaccine in the elderly in order to get a vaccine response. Not so with the Pfizer BioNTech vaccine. In those elderly patients, they still had a robust immune response, even in those greater than or equal to 75 years of age. It's interesting to look at the curves for the placebo arm and also the Pfizer BioNTech vaccine arm. You'll note here that the two curves are superimposable up until 12 to 14 days. Well, what happens at 12 to 14 days? That's when immunoglobulin comes into play. IgG is produced at 12 to 14 days, and that's where the two curves diverge. Now, you'll notice down here, I've circled that between the first dose, so after the first dose until the second dose that the vaccine is given, which is at 21 days, the efficacy is 52.4%. I'm going to show you data in a few moments that from day 14, that is over here, until day 21, the vaccine efficacy really rises precipitously once IgG is produced. You can see that up here as well in the inset, that the vaccine efficacy is actually 92.3%. So initially, there is no increase in IgG. IgG comes into play at 12 to 14 days, and that's when we have excellent protection against the coronavirus. Now, here is the Moderna vaccine. The Moderna vaccine is given in a dose of 100 micrograms, and you can see that from day 1 to about day 28, there is an increase, but then it quickly rises. So 7 to 14 days after the second dose of the vaccine, we have maximal antibody production. And right over here, we have convalescent serum from people who had SARS-CoV-2. They had the infection, and it's totally comparable to that. The number of antibodies, the concentration of antibodies is comparable to someone who has natural infection. But in addition to that, the Moderna vaccine produces a brisk CD4 response to the antigen, that is the spike protein antigen. And you will note here that at day 43, there is a robust response. CD4 cells come into play. They come into play after the antibody response. They come into play a little later on. That's when they come online, and it's an excellent response as well. That is, the T cell response is excellent. What about the AstraZeneca vaccine? Well, I mentioned to you before that the AstraZeneca vaccine is an excellent example of the vector-based vaccines. Here we have an adenovirus vector. It's a non-replicating chimpanzee simian adenovirus vector. And the genetic code for the SARS-CoV-2 spike protein is located inside the vector. What are some of the issues that we have to deal with in dealing with COVID-19 vaccines? Well, the first issue we want to know about is, are these vaccines going to be efficacious? Let's look at the Pfizer vaccine first. As I told you before, from the time of the first dose to before the second dose of the vaccine, we have vaccine efficacy of about 52.4%. However, at day 14, when IgG comes into play, it's being manufactured and it's present at days 12 to 14. So from days 14 until the second dose, the vaccine efficacy rises precipitously to 92.3%. And in total, after the second dose, that is 7 days after the second dose, the vaccine efficacy is 94.8%. What about the Moderna vaccine? Well, some people in the Moderna trial only got one dose of the Moderna vaccine. Vaccine efficacy, when assessed later on, that is after 14 days, even with one dose, was 80.2%. From days 14 after the first dose, that is 14 days after that dose was given, to the second dose, when the second dose was given, vaccine efficacy was 92.3%. Overall, from 14 days going forward after the second dose, vaccine efficacy was 94.1% with 2 doses. But the Moderna vaccine also offers a unique feature. The Moderna vaccine showed a lower prevalence of SARS-CoV-2 positivity by PCR in asymptomatic individuals. That is, it reduces asymptomatic carriers in the people who received the vaccine. Very important. A second issue that you want to deal with is, do people react adversely to the vaccine? Well, the most important adverse reaction is clearly anaphylaxis. That has been looked at and is the polyethylene glycol component of the lipid nanoparticle that is associated with this anaphylactic reaction. With the Pfizer-BioNTech vaccine, anaphylaxis occurs at an incidence of 11.1 cases per 1 million doses administered. With the Moderna vaccine, anaphylaxis occurs only 2.5 cases per 1 million doses administered. Now, there is another component of the lipid nanoparticle in the Moderna vaccine, that is tromethamine, that can also produce allergic reactions, but this is far, far less common. Now, another question you may ask yourself is, will these vaccines be effective against SARS-CoV-2 variants? The answer to it is simply yes. The Pfizer-BioNTech vaccine produces antibody that is neutralizing of the B.1.1.7 variant that is found in the UK. Both the Pfizer and Moderna vaccines did elicit neutralizing antibody against a number of SARS-CoV-2 variants. The Moderna vaccine itself, by itself, was looked at, and it elicited adequate antibody activity against the UK B.1.1.7 variant, but also against the South African B.1.351 variant. But this neutralizing antibody production was somewhat reduced compared to the antibody production against the B.1.1.7 variant. Now, the Johnson and Johnson vaccine, remember, this is a vaccine that is an adenovirus vector vaccine. One dose only is necessary. It has efficacy in up to 57% of the participants who were in South Africa who got this one dose, where the predominant South African B.1.351 variant is present. So this vaccine is also effective against the SARS-CoV-2 variants. Now, the AstraZeneca vaccine has also been looked at in the UK, and it has activity against the B.1.1.7 variant, but it's not quite as robust as what we talked about with the Pfizer and the Moderna vaccine, or maybe the Johnson and Johnson vaccine. Neutralizing antibody activity was 9 times lower against the B.1.1.7 variant compared to the natural occurring coronavirus. So against SARS-CoV-2 that was naturally occurring before we derived the variants, it was very active against that, not quite as active against the new UK B.1.1.7 variant. Well, what about COVID-19 vaccines in oncology patients? There are two principles that I have to outline for you at the outset of these two slides that I'm going to be presenting about the use of COVID-19 vaccines in oncology patients. The first principle is vaccine efficacy may be attenuated by the immunosuppressive chemotherapy that we're using. The second principle is it really is important to try to give the vaccine before the initiation of chemotherapy, that is 2 weeks before the initiation of chemotherapy. And you know why now. The reason for this is by 2 weeks, we are seeing the emergence of IgG. That's what I showed you from the clinical trials. That's when IgG comes online and provides protection. That is adaptive immunity protection. So what should we do for our oncology patients? I think it's a difficult scenario when we're dealing with an auto stem cell transplant. We probably should wait 2 to 3 months after the auto stem cell transplant before giving the vaccine, because we need some immune reconstitution, even more so when we're dealing with an allogeneic hematopoietic stem cell transplant. There, what we should do is probably wait for immune reconstitution that may take up to 4 to 6 months. With hematologic malignancy patients, it's best to try to start the vaccine series 2 weeks before chemotherapy is given. Remember what I told you, IgG comes online at 14 days. That's why you administer the vaccine 2 weeks before chemotherapy, and then you can deliver the second dose at a later date. Now, if you have already started chemotherapy in that patient and you want to deliver the vaccine to the patient, to start the series after chemotherapy starts, I think you may have to wait 1 month after the completion of chemotherapy. This is particularly pertinent to the use of rituximab in patients with lymphoma, and you know that rituximab causes a marked reduction in CD20 lymphocytes, and as a result of this, immunoglobulin may not be produced adequately. So please keep that in mind as well. Try to distance your vaccination as well from the administration of dexamethasone. What dexamethasone does, and it's often used as an adjuvant to prevent nausea with certain types of chemotherapy, it knocks down the lymphocytes. It causes lymphocytopenia. So try to distance your vaccine administration 7 to 10 days after the administration of dexamethasone. With checkpoint inhibitors, I'm not sure when to administer the vaccine. I think in this sort of situation, there's a bit of a cytokine release, and you may have to wait 6 months post therapy until you administer the vaccine. Similarly, with CAR T therapy, it is unclear when to give vaccination. Once again, I would say wait until the cytokine storm subsides, and you may have to wait up to 6 months. Now, on an individual basis, you always have to balance the risks and benefits of giving vaccination. I've already told you that cancer patients are at greater risk of more severe COVID-19 infection. So you have to balance the benefits of giving the vaccine with the risks. And at times you must go forward and give the vaccine in patients with cancer, keeping in mind that they are predisposed to a greater morbidity associated with COVID-19. So go ahead and give the vaccine. Now, in summary, what I'd like to say is COVID vaccines are here. We have two that are approved right now. The AstraZeneca vaccine will probably be approved in Canada in the next week or so. Thereafter, the J&J vaccine will probably be approved in the next month or so. And in the second quarter of 2021, we have a Novavax that is in phase 3 trials right now, and it may also be approved. Vaccines produce both an adaptive immunity as well as an innate immunity response. Recognize that. However, we also have to recognize that there's a dearth of data now for immunocompromised hosts. We don't have good, robust data at the moment. We're awaiting that. Hopefully, when the data is available, we will see an adequate response to these vaccines in patients with cancer. That's our concern right now. We want to make sure that they're protected. We're not sure if that will be the case. So vaccines will probably be efficacious, but their response may be blunted depending on the level of immunosuppression. And with that, I'd like to close. Thank you very much for your attention.